Hi, this is Alan Gardner, Senior Lecturer in Advanced Clinical Practice at the University of Central Lancashire, and thank you for watching this first part of a two-part series on the cardiovascular assessment. As you can see, this first part is dealing with history taking. So our video learning outcomes are to develop an understanding of history taking, and we're going to apply that specifically to the cardiovascular system. In fact, we're going to be even more specific with it, and we're going to apply it to the presentation of chest pain. As a learner, I've sat through several similar sessions to this in the past where whoever's been teaching has tried to approach the cardiovascular assessment from a very broad perspective, and in my experience it often becomes just a case of just a series of questions that can be applied to lots of different presentations, and I worry that there's an opportunity to become a little bit lost with that, and so I just wanted to try this more sort of focused approach. Once we've applied this thinking to chest pain, we can then go on to apply this approach to other presentations that are common to the cardiovascular system. I've chosen chest pain as it's the most common presenting complaint for the cardiovascular system. As we move on to the next slide, we can see that there are other presentations that we might come across with regard to the cardiovascular system, for example, palpitations or breathlessness, or even peripheral swelling with regard to edema. So our general goals with regard to history taking are to ascertain the nature of the patient's problem. Through the medical model, we tend to use like an open-ended question such as, how can I help you today? And that helps us to ascertain the patient's presenting complaint. Now, within this video, I'm trying to avoid getting into a kind of a general discussion of history taking, that for my students watching this, you will have already had a session on history taking and various different approaches. That we tend to use the medical model of history taking that goes through presenting complaint, history of presenting complaint and symptom analysis, through then kind of broadening out through past medical history, drug history, etc. And that's the approach that I'm taking here. Obviously, there are other approaches to history taking, but that's the one I've chosen for this this session. And as I said before, that once we've applied it specifically to chest pain, we can start to apply that thinking to some of the other common presentations in the cardiovascular system. As we start to gain information, or I prefer to see it as data from our patients, we can use this to begin to differentiate between all the vast range of potential causes for a patient's presenting complaint. Now, as I said before, we're thinking about chest pain specifically throughout this presentation, and there's a series of different cardiac causes, but it can also be a pulmonary or an extrathoracic etiology as well. So, for example, pulmonary causes might include pneumonia or pulmonary embolism. Extrathoracic causes can be gastroesophageal reflux disease or anxiety, and these are just a small selection of the potential differential diagnoses that we need to consider as we're structuring our questioning to rule certain causes in and rule others out as we progress through our history. Our history taking is also a really good opportunity to start to understand the baseline activity of a patient. So thinking about, for example, exercise tolerance. If a patient's complaining that they feel very breathless when they go upstairs and that this is a new complaint, this is going to be very different to between various different patients. So, for example, if their usual exercise tolerance is that they can only really go up 2 flights of stairs before they have to stop and take a break, that this is a much less drastic change in comparison to a younger, more athletic patient who can now only get upstairs before they start feeling out of breath, whereas usually they'd have really long exercise tolerance. Chest pain is one of the most serious complaints that we'll see from our patients. There's a series of very serious underlying etiologies that might lead to chest pain. I've already mentioned a few of them, those being like acute coronary syndrome, which I refer to toward the bottom of this slide, ACS. That's an umbrella term for ischemic heart disease that can cause cause myocardial infarction or angina pectoris. But chest pain can also be caused by pneumonia or pulmonary embolism, as well as some of the more minor etiologies as well. We've already mentioned that anxiety or panic disorder can contribute to chest pain, just as gastroesophageal reflux disease can. Most importantly is that we know that this is the most common symptom of coronary heart disease, as well as other cardiac problems such as infective pericarditis. We're going to need to use a systematic approach, which is the same as we do for all of our history taking, but this systematic approach can help us to add structure to our questioning, and we've got various tools to be able to do that. So we can use we've already mentioned the medical model that's going to give us structure throughout the throughout the history taking, but there's tools such as the Morton symptom analysis tool, which I feel really comfortable using. I think that this expanded PQRST tool is a really useful mnemonic for analysing symptoms, and you can apply that not only to presenting complaints associated with pain, but to lots of other complaints as well. Whereas some people prefer to use Socrates, that's specifically designed for analysing pain. So either of these will be useful. I'll be using the OPQRSTU tool throughout this presentation, which starts with onset. Understanding the nature of the onset of the problem can be really important as quite an early way to start to differentiate between different causes. So for example, here it mentions that if the chest pain is there at rest, then that's going to be highly suggestive of acute coronary syndrome such as unstable angina or myocardial infarction. Whereas if it's only there during exertion, and that might be more indicative of stable angina, we may even go on to ask the patient if they already use a GTN spray, for example, has the GTN spray relieved the pain? It mentions here post-traumatic pain might be more suggestive of something like a fractured rib or a pneumothorax. So that's starting to kind of shape our formation of hypotheses quite early on in the history taking, and helping us to rule in or out, or at least sort of make certain diagnoses more favourable, and we become more suspicious of certain diagnoses and less suspicious of others. With regard to the onset, we also need to know when did the pain start. That's a really useful question to ask. So did it start a few hours ago, in which case that's again going to be more closely associated with acute problems such as ACS. Whereas if it's a pain that started a few days ago and has become gradually worsening, that might be more suggestive of perhaps an infected cause like pericarditis or even pneumonia. That this is a pain that's caused someone to wait a few days before they present. Now, obviously, there are exceptions to this sort of thing, but this is just sort of taking the typical data that we get from patients and how these conditions typically present. Inquiring about aggravating factors, or as the PQRST mnemonic refers to them as palliative and provocative factors. So actually this isn't just aggravating factors, but this is factors that make the pain worse, but also is there anything that makes the pain better? Knowing whether or not a patient has taken any analgesia can be really useful, because then we know, well, if they've taken some GTN, has that made it better, or have they taken some paracetamol and has that had an impact? And if they've taken these things and it hasn't helped, then again that can start to shape our decision making. That if a pain isn't better with GTN, then that could be because it's not a cardiac cause, or it might be because they've got some serious ischemic changes going on that won't be relieved by GTN. So, for example, an exertional chest pain here is suggestive of cardiac pain. So if you ask the patient, well, is there anything that seems to make it worse, and they say, well, it's definitely worse as I'm walking around, or it was worse when I'm at work if they're doing a physical job, then that might be suggestive that it's a cardiac pain. Understanding that a pleuritic chest pain is associated with quite a sudden or sharp sensation. People might describe it as being stabbing or even burning in their chest, and it's usually exacerbated by inspiration. So if the pain tends to get worse as they breathe in, as we progress through our PQRST mnemonic, we'll actually get to next we get onto the quality of the pain. So we can ask them to describe in words like sudden or sharp, or when we get onto the next page, we'll talk about some crushing type chest pains. But understanding that a pain that's worse on inspiration and is described in these terms is what we refer to as a pleuritic chest pain. So that can be caused just by a simple viral infection, or it might be associated with a pneumonia, for example. But we know that chest pains can be caused by gastrointestinal problems, such as gastroesophageal reflux disease. So does the pain get worse after food, in particular spicy foods or caffeinated drinks, and that can be more suggestive of a reflux pain. If it's worsened by leaning forward or lying down, in particular by lying on the right hand side, and that again, that might be suggestive of gastroesophageal reflux disease. I've already mentioned this idea of is the pain relieved by GTN, which again would be strongly suggestive of a cardiac ischemia. But that would be suggestive of angina, whereas your typical typical chest pain and myocardial infarction won't be won't be relieved by GTN spray. If the pain's actually improved by taking some reflux medication such as calcium carbonate tablets or Gaviscon, that this would then help shape your decision making to think, well, could this potentially be a gastroesophageal reflux disease? Let's move into this final point, that this pain actually being relieved by sitting forward is suggestive of pericarditis. But we'd also potentially have a picture of the patient with fever, that as we get onto our associated symptoms, we're going to try to broaden out this picture of pericarditis, that it's not just about this single piece of data that the pain's going to be made better by sitting forward, that we're trying to build up this whole picture of the patient. So if you do come across someone who says, well, it's more comfortable to sit forward to diagnose pericarditis, we're also thinking of some other symptoms as well. These patients often complain of palpitations as well as chest pain, so that's this unpleasant sensation of their heart beating in the chest. They're likely to complain of fever and even have an objectively measurable low-grade pyrexia as well. They may even have some tachycardia and dyspnea as well. As we move on to the exploring the quality of the pain, this is about asking the patient to actually describe in their own words what the pain feels like. So you're probably already familiar with this idea of a crushing chest pain. And we're trying to encourage the patient to actually give us some rich data as to how they describe the pain. And some people might need some prompting, but it's important that we don't lead the patient as well. So we might use prompts. For example, we'll ask the patient, well, how would you describe the pain? And some people might reply, oh, well, I don't really know. And so it's important then that we just give them a range of different options. So it's saying, well, would you describe it as being like a tight pain or a sharp pain, or is it a crushing pain? And that this is, we've got some potential to lead them, but we're trying not to lead them to a particular answer. So by giving them a range of different options, that's probably the easiest way to do that. We can see here then that our sort of crushing central chest pain is absolutely typical of acute coronary syndrome. So again, this is including MI and angina pain. Interestingly, we know that although this is more common in male patients, that women tend to describe their pain quite often in other terms rather than using this sort of typical crushing chest pain. In fact, in comparison to men, women are more likely to not experience the chest pain as typically and be more likely to complain of some of the other symptoms like jaw pain or breathlessness when they're suffering from myocardial infarction. A tearing pain that radiates into the back might be characteristic of aortic dissection. So again, it's important to ask our patient to describe that, and that we might inquire specifically about back pain, or as we're inquiring about the quality of the pain, that we ask, well, is it would you describe it as a tearing pain, and does it travel into the back? Again, being careful not to ask leading questions. And we've already mentioned pleuritic chest pain, that again, that this is this sort of sharp or stabbing pain that tends to be worse with inspiration. And if a patient describes it in these ways, then it might be more suggestive of a pneumonia or a PE, but it then becomes unlikely to be an ACS that we're dealing with in this case. Next, we can inquire about any radiation of the pain, and as it says here, that pain radiating to the shoulders or arms or jaw can be typical of acute coronary syndrome. We can see from this diagram on the right side as well that the cardiac chest pain can radiate into any of these areas. And as I alluded to on the previous slide, that we know that women who present with ACS are more likely to complain of pain into these areas where it radiates to, as opposed to chest pain, or at least more likely than men to complain of those. Chest pain can radiate into the back, and we've already mentioned that this is suggestive of aortic dissection. There's several pain severity tools that we can use. I tend to use a score of 0 to 10, where 10 is the worst possible pain and 0 is no pain. And this can give us a really good opportunity to start to understand the patient's own experience of the pain that they're complaining of. But it can give us a really good indicator as to the likelihood as to whether or not we're dealing with an acute or life-threatening problem, that a severe pain, if the pain scores closer to 10, then we're more likely to then start to take it quite seriously, and that's going to shape our suspicions toward ACS, for example, or even we might get severe pain in pulmonary embolism or some pneumonias as well. But one caveat to this is that we've got to be aware of what's referred to as silent or unrecognized myocardial infarction. This is particularly common in patients with diabetes mellitus. In fact, I've only ever seen it once in my career as an ACP, but this was a gentleman who presented with very vague sensations in his chest. It wasn't a pain. In fact, he denied any pain. It was just a kind of this vague sensation. That's pretty much all he described it as. There was very little else within the history to suggest anything serious. But on ECG, that was the only way really to pick up on him having an ST elevation MI. But he did have a history of diabetes mellitus, so he was having this painless silent myocardial infarction. Obviously, that could have been potentially life-threatening had I sent him home without the appropriate investigation on that day. The timing of the chest pain can be really useful in helping us shape our differential diagnoses. That central crushing chest pain lasting for more than 20 minutes is again very highly suggestive of acute coronary syndrome. And we can structure our questioning to ask, well, how has the pain changed over time? So this, again, thinking about a pain that's becoming gradually or rapidly worsening is again going to be suggestive of something more serious, as opposed to a pain that kind of waxes and wanes. So if it's coming and going throughout different parts of the day, or even coming and going throughout different parts of the week, that's going to lead to us thinking differently about this pain than someone who's got an acute onset of something that's getting quite rapidly worse. And whether or not they've had the pain previously as well. So this can be a really useful question to ask the patient, well, have you experienced this pain before? And I know I've seen patients who said, well, yeah, I've had this pain before. I've had it 10 years ago when I had my last heart attack, or Um, or they might say, well, I've had it previously when I've had a PE in the past, for example. So these are useful questions to help us understand the context of the patient's pain and to help us shape our potential differential diagnoses. Morton's symptom analysis tool traditionally finishes with T for timing, but this expanded one has this extra U at the end, which stands for how is the pain or how is it affecting you? And I think this is a really useful question for starting to contextualize the patient's lived experience of whatever their complaint is. So in this example with chest pain, it means that a seemingly innocuous complaint can sometimes have some quite serious implications for people. Using the example outside of chest pain, I used to see patients in ENT with antisocial snoring, and what seems at times to be an innocuous complaint can actually lead to by asking, well, how is it affecting you? That these patients are often sleeping on the couch, that their marriage can be on the verge of collapse. And it can be the same with chest pain as well. So if for example, with our questioning about severity, the patient might say, well, it's about 2 or 3 at its worst, and you think, well, that's a fairly mild pain, it can't be bothering you too much. But as we ask, well, how's it affecting you? It can help broaden out their experience and give them the opportunity to talk about any anxiety they have about it, especially in the presence of a strong family history of cardiac disease, or if they've had a relative, like a direct relative, for example, their parents, if one of their parents has died quite young of an MI, then that can lead people to be particularly anxious of any chest pains, and even if it's only quite a mild one. So yeah, just kind of reiterate, this just helps us kind of broaden out the context of the patient experience here, and gives us some really valuable insight into what they're thinking and feeling. Speaking of which, we can then move into our ideas, concerns, expectations. And quite often you'll see this at the end of the history taking. I put this earlier on. So this allows us now to move on from being very much focused on analysing the presenting complaint to now starting to ask the patient questions like, well, what are your thoughts about what's happening? It's really important to understand the patient's perception of their illness. And it's really important in chest pain, as people can be really anxious about this. Even if our thinking is that it's not going to be a serious etiology, that it gives the patient an opportunity to be quite open about their ideas, what they think it is, what they're particularly concerned about. We've already talked about this idea of people having a strong family history of cardiovascular disease, or in particular mortality as a result of cardiovascular disease. So it gives the patient an opportunity to talk about that, and so that we can be quite open with our patients about, well, what are their expectations, and how can we meet that, or if we think that there's some unrealistic expectations, how can we mitigate that? And to do that quite early on in the consultation can be really useful. We can move on to our associated symptoms, and we might need to ask about these quite specifically. So some people might use quite a broad question, like, well, tell me about any symptoms that you have, but we know that patients can sometimes think, well, I'm not going to tell them about some nausea because I don't think that's relevant. But actually it's up to us as the clinician to decide which ones are relevant and which ones might be red herrings. So we can ask specifically about nausea or vomiting. And they say diaphoresis, that's perspiration, that might be more a sign that we see as part of our examination, but we can ask, well, when the chest pain came on, did you find that you were really sweaty? Did you go pale? So that if it's something that happened before the consultation and has then since settled down, we can get that subjective information from the patient by specifically asking about it. We can ask if there's been any fevers or night sweats, if they felt hot or cold particularly, but that might then lead us more down the route of thinking about infective etiologies like pneumonia or pericarditis or costochondritis. Have they had any shortness of breath? Again, this if we ask specifically about this might channel our thinking more toward a pulmonary etiology like pneumonia or pneumothorax, but we also know that it's present in heart failure as well. We want to ask specifically if there's been a cough, or whether or not they've had any sour taste or or if they experience what they'd interpret as acid reflux, which again might be suggestive more of a GI cause to their pain. As we progress through the medical model, we get into the more holistic side of our history taking, as we need to move away from sort of purely symptom analysis and focusing on the presenting complaint. We now need to kind of broaden out our picture of the patient as a whole and contextualize where does this complaint sit within the rest of the patient's life. So for example, with the social history, this is a really important opportunity to ascertain any lifestyle risk factors. So for example, smoking and alcohol intake, that as we understand whether or not a patient smokes, that's going to increase our suspicion of cardiac causes. Just as understanding, well, what does their diet look like? Is it high in fats? Are they living quite a sedentary lifestyle, both occupationally, or do they not take very much exercise? Again, this is going to increase our suspicion of cardiac causes for this chest pain. But if they're as well, I mean, with regard to diet, that if they're drinking a lot of alcohol, drinking a lot of caffeine, eating eating a diet that's quite rich in fats and processed sugars, that this might also make us more suspicious of gastrointestinal causes as well. This is also a really good opportunity for us to ask about stress and whether or not they have stress in their personal or occupational life that might place anxiety or panic disorder higher on our list of suspicions. The problem with this is that we need to consider this as a diagnosis of exclusion. So we need to exclude any other, in particular, life-threatening causes and any other physical etiologies for the chest pain before we start to consider this to be as a result of anxiety or panic disorder. With regard to our family history, this is a good opportunity to establish whether or not there's been a strong family history of anything that might cause chest pain. So we're thinking specifically about coronary heart disease. Just going back to social history though, and we mentioned a sedentary lifestyle, just broadening out our history away from the cardiovascular causes, that sedentary lifestyle or recent inactivity, such as long haul flights, might be more indicative of a PE. So we need to use our social history to start to ask questions about that sort of thing as well. With regard to our drug history, it's really important to actually inquire about this. I've had students in the past say, well, I don't take a drug history because it's all there on the primary care record, for example. But I think we need to actually take responsibility for asking the patient specifically about their medications, because just because a drug's prescribed, it doesn't mean that they're necessarily taking it, and they might be taking it differently to as it's prescribed anyway. So we can ask about prescribed medication, and there's a list of them here that will increase our suspicions for certain causes. So if people are on anticoagulants because they've had a recent DVT, that might put them at an increased risk of pulmonary embolism. If people are already on antiplatelets for coronary artery disease, then it might increase our suspicion of acute coronary syndrome. Another example is that if they've had antibiotics that they've been treated recently for an infection, in particular a chest infection, that might increase our suspicions that this has progressed to a pneumonia. So ensuring that we actually ask specifically about some of these medications can be really useful. But it's not just about prescribed medications that we need to ask about over-the-counter drugs, and in particular recreational drugs, that we know that there's a quite significantly increased risk for acute coronary syndrome if you use cocaine in particular. Inquiring about our past medical history helps us to broaden out our perspective of the patient's general health. Do they have multiple comorbidities? Do they have pre-existing cardiovascular disease such as hypertension, or have they already been diagnosed with angina? Do they have hyperlipidemia? This is an opportunity for us to actually identify predisposing factors that are going to put them at increased risk of a cardiac cause for their chest pain. But there's other non-cardiac causes that we can ask about as well. So have they previously had pneumonia? Do they have COPD? So this could be an infective exacerbation of COPD. Have they had pneumothorax in the past? So for example, with spontaneous pneumothorax in young patients, that we know that they're at an increased risk of having pneumothorax again. Just as if patients have already had a PE, that they're at an increased risk of having a PE again. So this is a good opportunity for us to ask specifically about some of these predisposing illnesses and conditions that are going to put them at an increased risk of certain conditions, and therefore help us shape our hypotheses in one direction or another. Speaking of hypotheses, we can also use some heuristic thinking. So heuristics are kind of rules of thumb, that these are tools that we use as part of our clinical decision making, and you'll come across several of these throughout your career. So for example, with regard to a chest pain, that we tend to treat chest pain as a cardiac cause until proven otherwise, but we can use more specific heuristics. So if the pain is a pressure or pressure-like sensation, if it's tight or crushing in nature, if it's radiating down both arms, and if it's associated with exertion, nausea, vomiting, diaphoresis, then we know that that's very likely to be ACS. Whereas to send our suspicions in other directions, if it's more of a kind of a stabbing or sharp pain that's sort of more associated with this pleuritic chest pain that we've already described, if it's positional or if it's associated with being inframammary, so that means sort of within the breasts, or we can reproduce it with our palpation, so we're going to palpate for tenderness, then it's unlikely to be acute coronary syndrome. We can more channel our hypotheses towards some of these non-cardiac causes of the chest pain. This gets us toward the end of this presentation now. We've broadened out the whole consultation, probably missing a couple of important parts of the medical model, so we haven't looked at the review of systems specifically, for example. But I think that probably one of the key takeaways in order to start to broaden out your history to the rest of the cardiovascular system is to start thinking about understanding common presentations and actually understanding the theory of presentations of disease, as well as gaining more exposure to them practically. So what I mean by this is to actually read the typical history. So here on the right hand side of the screen, you can see part of the typical history of myocardial infarction. This comes from the Medscape or eMedicine website that you can see the link to here. And I put the circles around the presentation box, and then you've got the history. And actually what you get is really useful sort of quick access information or summaries of presentations, and you can find loads of them for cardiac or non-cardiac causes or etiologies. There's all sorts of things on there. So I find this is a really good website. A lot of trusts subscribe to UpToDate, so you can see the link to that. Not all trusts do. My access through UCLan doesn't actually give me access to UpToDate, so I tend to use the Medscape resources that are actually American. So there's sometimes some parts of it that aren't specific or aren't applicable to us in the UK, but they're updated regularly. And I think, as I said, that the main part really is that they give you a really easily accessible summary of the history of various diseases and conditions. So it's a good opportunity to actually read up on the presentations that you're seeing in practice, and understand how your patient's presentation actually relates to the sort of the theoretical or typical presentation that we see in these diseases. And that gets us to the end. The next slide is just the references. So just thank you very much for listening. You can now move on to part 2, which is the cardiovascular examination.